Well, let me just say thank you very much for being here and for the opportunity that I have to collaborate with this meeting. And this is my last presentation. And this is an area that I do a lot of gestational diabetes treatment, but it's an area that is very poorly addressed. So let's see how we're going to do in the next few minutes. And I don't want to insult anybody. I know you know this, but I just wanted to give you a background. Gestational diabetes, of course, is a disease or is a condition that appears during pregnancy. So you have to differentiate those patients who have diabetes pre-pregnancy for those who develop pregnancies during the second trimester. Usually happen in the second trimester when the placenta is large enough that produce a hormone that is called human placental lactogen that blocks the action of insulin. So we screen at the 24, 28 weeks because that's when the placenta is large enough to produce these hormones. So before that, it's very unlikely, except for those patients who have family history, those who have previous history of gestational diabetes. If somebody has gestational diabetes now, in the next pregnancy, more than half of them are going to have gestational diabetes. So you're not going to wait until 24, 28 weeks. We would like you to start screening these patients early on. And of course, those who have elderly and very obese patients. The prevalence changes from country to country. In the United States, it's somewhere around 7 to 8%, but in parallel with the increased body weight of the population in the United States, it parallels the prevalence of gestational diabetes. So the rate of gestational diabetes has increased in the last few years. I already mentioned, every pregnant woman have a placenta, that's right, and produce this human placenta, lactogen, and other hormones. But not everybody develops gestational diabetes. And it all depends what is the condition of insulin secretion or the pancreas in these patients. A woman with good pancreas, enough insulin secretion, would never develop gestational diabetes. So they have an impair in insulin secretion. So that is related to two things: a genetic predisposition, okay, and second, the insulin resistance that you're going to see. And here shows the rate of insulin requirements during pregnancy, or is the equivalent of the insulin resistance that you're going to see. So if you look at this, it's up to age 20. Insulin doesn't change. The insulin sensitivity is the same, and it's after the 20 weeks you start going to see the insulin resistance. So that is why we test for screen between the week 24 to 28, trying to get the women diagnosed before they achieve gestational diabetes. In the way that we will see in a couple of slides, gestational diabetes is associated with maternal and fetal complications. Other risk factors in addition to age is race is important. Maternal age at pregnancy over the age of 25 increase the risk. So if you are below 25, the risk is very small. Body weight is important. And of course, as I mentioned before, is the previous history of gestational diabetes. Body weight is perhaps the most important risk factor, together with genetic or race, in the prevalence of gestational diabetes. And we all know that it's associated with macrosomia. And because of macrosomia, they're going to have several problems related to the delivery. They have the other thing that you're going to see is that half of the women who have gestational diabetes will develop type 2 diabetes. Of course, this is because those persons who develop gestational diabetes do not have enough insulin reserve. So after a few years after delivery, after pregnancy, they're going to have type 2 diabetes. So the recommendations right now is that somebody who develops gestational diabetes, diabetes goes away after the delivery, they should be retested, or they should be tested with an oral glucose tolerance test or with hemoglobin A1C later on, and follow these patients every 1 or 2 years, because the rate of conversion is somewhere around 8 to 10% per year. 50% of women who develop gestational diabetes will develop type 2 diabetes within the next 5 years, 50%. And there is also associated with increased cardiovascular problems. Most important is the problem that we have women with gestational diabetes is the child, is the fetus. They have fetal macrosomia, and that is usually a problem. They develop shoulder dystocia, and there is also an increased risk of hypoglycemia in these kids. I'm not going to talk about the diagnosis of gestational diabetes. It was presented before. But in the United States, there is a big problem. The ADA suggested that we should join the rest of the world and do the 75 grams oral glucose tolerance test that I think is the way you diagnose gestational diabetes. In the United States and in Canada, we still use the two-test approach. We do the 50 grams oral glucose tolerance test, and if it's positive, we go for a 100 grams oral glucose tolerance test. This is the way how the obstetricians are going to diagnose diabetes. But we think that the 75 grams, what you do and the International Diabetes Federation recommend, is the best way to go. So the lecture is about prevention strategies. So these are what you can do is diet, lifestyle intervention based on diet and exercise has been shown to be very effective. And the question is, does medications can prevent gestational diabetes? There are a large number of studies that have been shown that diet and exercise are effective. This is a meta-analysis of different studies on the role of nutrition and nutrition manipulations. And you will see that significant decrease the risk of gestational diabetes. Physical activities have also been shown to be effective. And physical activity produced a reduction of gestational diabetes independent of changes in body weight. So we don't want the women during pregnancy to lose weight, that's right, they should gain weight. And the weight gain should be according to what the gestational body weight of the female, of the woman. Those who are obese, we want to gain less weight. And exercise, how it works, is not by weight loss, but exercise increases insulin sensitivity. It makes the insulin that the body produces to be more effective in glucose disposal. And that is why the physical activity is recommended. There are certain type of exercise that the women should do. That's right. Walking, biking, swimming is very effective. The gestational diabetes should not be doing too much weightlifting or several exercises, depending on the type of exercise. This is a recent study that I think shows a very important recommendations on the lifestyle intervention. Perhaps very surprising is how effective it is in Finland. They were able to prevent gestational diabetes in 39% if you do exercise and diet. This study involved a total of close to 300 patients. Half of the patients were involved in intensive physical activity, counseling, and weight control, and the others just led it standard of care. They did an oral glucose tolerance test with these patients at 24, 28 weeks, and they started this lifestyle intervention as early as possible during the pregnancy. And here you have that those patients who were on the lifestyle intervention reduced the prevalence of gestational diabetes from 22% to 14%. So an amazing response in these patients. In addition to prevent gestational diabetes, they were able to produce some, little weight differences, and the physical activity was very effective. So in Finland, they got a 39% reduction. So in Atlanta, Georgia, in African American women, we decided to do a study to determine if we can prevent gestational diabetes in African Americans obese women. And we designed an intervention, with lifestyle intervention, and trying them to do between 150 to 100 minutes a week of exercise, and they were all, we gave a nutritional support, and we saw them every month. not as intensive as the study in Finland, but this study was supported by the IDEC. So we took patients, first OB clinic, less than 20 weeks, we started a lifestyle intervention. We screened like 11,000 patients. We did all kind of measurements at the beginning, and we randomized patients to regular care or lifestyle intervention. Can we prevent gestational diabetes in African Americans? So this is the physical activity recommendations that we observed. So they did more exercise, good. And that was significant. So we asked the patients to do exercise for about 180 minutes, and they did a little better. Then we said, what happened with the prevalence of diabetes? Unfortunately, in our population, was not able to prevent gestational diabetes. So what explained that in Finland, you got 29 or 30% reduction of GDM, and why we couldn't do this in African Americans? So maybe what is that explained is maybe the level of education. Maybe interventions should be different, so the response to intervention would be different among different countries. I don't know if you have done the studies on prevention of gestational diabetes in India, but in Atlanta we were not able to decrease that. We did oral glucose tolerance tests to determine insulin secretion and insulin action, and unfortunately we didn't see much of a difference between them. So a little frustrating to us. In African American, we have now, and in Latinas, we have now a program that we ask these women to start early on lifestyle intervention, trying to have a good diet and exercise for about 150, 180 minutes. However, we have not seen much of a change. So, see, lifestyle intervention works or doesn't work. It depends what area of the world you are. So what about medications? Can we use metformin? Most women with gestational diabetes in the United States are treated with oral agents, more than insulin now. If you use metformin early on, can you prevent the development of gestational diabetes? And there are studies in two sets of patients. One is in studies in patients with polycystic ovarian syndrome, and the others are in obese. So this slide shows the metformin use for prevention of gestational diabetes in obese women. They took women who have a BMI greater than 30, so they were obese, and they have 164 patients. Half were given metformin. They were given 850 twice a day, and half were given placebo. And what you have in here is the fasting blood glucose in these patients, glucose in 1 hour and at 2 hours. Metformin was not able to produce improvement in the oral glucose tolerance test in these women when they're given during pregnancy. In these studies, the use of metformin failed to prevent gestational diabetes. This is another study that was published recently in Lancet Diabetes and Endo. Again, they took women who were obese, all of them. They were given metformin or placebo. And what you have is that the rate of gestational diabetes was 24% in the placebo and 18% in women taking metformin, although the 6% was not really significant difference. If you look at the complications, I say, well, okay, what about body weight? What about C-sections? Absolutely none of these factors were positive. There was no difference in C-sections. There was no difference in complications in preterm delivery or hypertension. A second study that had been shown that in women, you cannot prevent gestational diabetes. Have you known many women with polycystic ovarian syndrome are given metformin to improve the PCO state? So there are 2 or 3 studies in the literature, I will just present 2 of them, that they were given metformin for PCO, they got pregnant, and they continued metformin during pregnancy. And the question is you continue metformin in this woman, can you prevent gestational diabetes? It is clear that a woman with PCO is more likely to have gestational diabetes than women without PCO. And what they observed, this is a meta-analysis, and they have 5 different studies. Although the numbers are not too large, none of these studies shows that you can prevent gestational diabetes. So in women with PCO, the recommendations, at least of the Endocrine Society, is that you should stop metformin as soon as the patient gets pregnant. So many doctors continue metformin trying to, quote unquote, prevent gestational diabetes. That should not be used. And there is no benefit of using metformin or continued metformin after the pregnancy has been confirmed in women with PCOS at all. So can we use metformin for GDM prevention? There are multiple studies that have shown that it fails. So you should not use metformin as a prevention of diabetes in this woman. Can you use any other type of medications? And the answer is absolutely no. So what we know is that in high-risk populations, so women who are over the age of 25, those who are obese, a previous history of gestational diabetes, lifestyle intervention should be instituted as soon as the first time that in the first OB clinic when the pregnancy has been confirmed. In some countries, not in every country, lifestyle intervention has been shown to be quite effective. You need frequent visits to the doctors, an intensive lifestyle intervention with diet and exercise for at least 180 minutes a week. In Finland, that decreased gestational diabetes by 30%. We tried to reproduce this data in African Americans in Atlanta, and we failed to do that. So every country must have a different response to this. So the second is intervention with medications. The number of people in the United States who are continuously being treated with metformin for prevention of GDM is absolutely out of this world in America. And that practice needs to stop because multiple studies have shown that metformin in women who are obese or women with PCOS does not result in prevention of GDM. So any one of you is like Americans giving metformin during pregnancy, that practice should be stopped. The only thing that it works is the exercise in these patients. Again, it's walking, yoga, and swimming or bicycles. And some bicycle, stationary bicycle is okay. The problem, make sure that there is decreased trauma in these patients. So there are several things that you can do during pregnancy. So this is my last presentation, and I'll be leaving, I guess, this afternoon. I just wanted to say thank you very much, and hopefully I'll see you next year.